Hello everyone, I'm Dr. Zhou Qihao Chu from Taiwan. It's my great honor to introduce our technique, which was initially developed by Dr. Alexander Lederman from Switzerland and modified by Dr. Alberto Guevara in Mexico. We have nothing to disclose regarding this technique. The indications and contraindications are as follows. This is a 26-year-old male patient with more than 3 times of anterior shoulder dislocation when playing volleyball. There's no obvious granule bone loss on the preoperative X-ray, but a small bony Bencal lesion and on-track heel sex lesion, which is ideally the candidate of this technique. The patient is put in a Biceps position. Typically, 4 arthroscopy portals are necessary. The anterior portal should be positioned low enough to provide a suitable angle for placing the drill device at the 4:30 o'clock position of the right glenoid. First, we introduce the scope from the posterior portal to see if there is a slump lesion, the long head of the biceps condition, and the size of the heel sex lesion. The rotator interval is widely opened. The split in the middle of the subscapularis muscular part can be performed at this point. The scope is then introduced into the glenohumeral joint through the rotating interval from the anterior lateral portal, confirming the position of the heel sex lesion. After footprint debridement, a suture-based anchor is introduced through the posterior portal, aiming at the deepest part of the heel sex lesion. After passing the sutures through the infraspinatus muscular tendon junction, the sutures are left without tying to provide more space in the glenohumeral joint to perform the DAS procedure. Viewing from anterior lateral portal, a low anterior portal is then created. Care must be taken to ensure the drill device lies at the edge of the anterior glenoid. A 6 mm drill is then used to prepare the hole at the edge of the anterior glenoid rim at 4:30 o'clock of the right shoulder. The hole will be 4 to 6 mm wide and 20 to 25 mm deep, depending on the preference of the surgeon and the size of the long head of the biceps. Then the scope is retrieved to the subacromial space to find out the biceps. The transverse humeral ligament is released adequately to facilitate bicep mobility. Some hidden lesions will sometimes be found inside the bicipital groove. We have to make sure the biceps is easily moved medially to provide a sling effect after the glenoid fixation. Then the scope is moved inside the glenohumeral joint. The biceps tenotomy is performed. It should be tenotomized at the most proximal part of the supraglenoid tubercle, providing the longest possible distance of the biceps for further fixation. Then the biceps is exteriorized through the anterior portal and secured using a speak weight technique with sutures 20 mm from the proximal tendon. Viewing from the anterior lateral portal, a suture retriever is advanced from the posterior portal through the subscapularis muscle split initially made to grab the suture and shuttle the biceps inside the glenohumeral joint. The sutures of the biceps can be retrieved anteriorly again from the rotating interval through the anterior portal, ensuring it passes through the subscapularis split. The 2 suture limbs fixing the biceps are shuttled through the eyelet of the tenodesis screw. The biceps passing through the subscapularis split is fixed into the glenoid hole we just created, with the screw entering through the rotator interval. Care must be taken to ensure that the sutures 20 mm of the biceps is inserted into the glenoid hole for better fixation. The additional fiber wire inside the biotenodesis screw can be used to perform another Bencal repair. After the DAS and Bencal repair, the suture passed through the infraspinatus can be tied to complete the Remplissage procedure. The fixed biceps now provides a sling and hammock effect. The cartoon picture of the whole construct and the postoperative X-ray is shown here. Thanks for your attention and welcome to share the technique.